And good afternoon, and thank you for joining us today. I'm Amanda Nelson with the Office of Aging and Disability Services. Today, we're joined by all of you, as well as our esteemed presenter and colleague from North Country Associates, Kim Dufour. Today's call is the third in our 2026 QuEST series. For anyone who's new to QuEST, it's the technical assistance arm of Maine's value-based purchasing initiative for nursing homes. QuEST stands for Quality, Excellence, Staffing, and Teamwork, and is designed to assist nursing home leaders on their quality improvement journeys. If you have questions or would like more information, you can email oads.nfquality@maine.gov, and Chelsea will put that in the chat too. While 2025 focused on learning about topics like value-based purchasing, culture change, and the five-star rating system nationally, 2026 is really centered around our own Maine leaders sharing the knowledge and experience of their own quality improvement journeys. A couple of housekeeping notes: if you haven't already done so, you're welcome to drop your name and the nursing home or organization you represent into the chat. We are offering certificates of attendance for licensed administrators today upon request. Please only submit a request for a certificate if you're a licensed Maine administrator and you attended the entire call. As a recognized continuing education sponsor of the Maine Nursing Home Administrators Licensing Board, we do adhere closely to the board rule, and there's no partial credit given for your attendance today. If you would like a certificate of attendance, please just drop an email to that email I gave you a minute ago and make sure that's within 30 days of the call. Our call today is being recorded. The recording, as well as the slides, will be posted to the Rate Reform website, and the materials will also be added to the SharePoint site. If you don't already have that website, Chelsea will drop that into the chat as well. So on to the show. Kim Dufour is the Vice President of Quality Clinical Services and Quality Improvement and has worked in healthcare for nearly 30 years. Her experience began as a certified nursing assistant while in high school, and then as a licensed practical nurse, becoming a registered nurse in 1999. Kim's nursing career has always been in the long-term care setting, with the first 10 years in the ICF IDD setting. She has worked with North Country Associates since 2005, working in various capacities as a MDS coordinator, a nurse manager, a director of nursing services, and now in her current role. In her present position, Kim works collaboratively with all of the NCA facilities to ensure delivery of high quality clinical care with a focus on quality improvement. I'll hand it over to Kim Dufour.
Thank you, Amanda. Welcome, everyone. And my biggest goal for today is I hope that everybody is able to walk away with something that they did not know at the end of this presentation. So we'll get started. So we're going to be covering quality indicators and quality measures. Okay, so quality indicators and quality measures. So the industry term is essentially using evidence-based forms so that we can track healthcare performance, safety, and resident outcomes. So that is the industry term. And then we're going to go into the five-star rating. So jumping from quality indicators to five-star ratings, why do we think that quality indicators are so important? And that is because it is one of the three components that actually factor into your five-star rating. So why is that considered to be important? Essentially, it's because our world is actually evolving on a technological basis. And so right now, what we are seeing is tech-savvy customers. So we have tech-savvy customers that are actually looking for placement for their loved ones. So they're going to be looking at five-star ratings to see if this is the facility that they want to entrust us to care for their loved ones. It's also a place where employees are looking. So you have potential employees that are looking at your five-star ratings to see if this is actually an organization that they want to, to join and actually work at. And then we also have insurance companies. There are many commercial insurance companies, Medicare replacement companies. They're looking at your five-star ratings and they want to see what that rating is in order to make an informed decision for themselves to see if they actually want to partner with you. They want to do their homework because they want to make sure that they're satisfying their customers. So you're going to see that quality indicators and quality measures kind of goes full circle and looks at a couple of different things, five stars actually being very important. Um, okay, so this component, so there are three components that that are part of five stars. The quality indicators and quality measures is the one that you're going to be able to see the quickest change. And it is the one component that changes on a monthly basis. The other two components, staffing, based on your PBJ, which that information is only submitted on a quarterly basis. And then you have the health inspections, which is only changes once a facility has gone through their annual survey and or complaint investigation. So you can kind of see how those other two measures are actually held at the mercy of either a survey and or a quarterly submission of data. Your QI QMs are the one thing that will give you that positive, quick change. So that's why you want to make sure that you're always looking at this very quickly. And then the one thing too, I just wanted to kind of add at this point, your quality indicators and your quality measures on your five-star rating, if you have a five-star under your quality indicators and measures, it can actually give you an overall star for your overall star rating. The same is true. If your quality indicators and quality measures are at a one star, you can lose an overall star. So it's very important that you look at this, that you work this, and that you're able to manage it because it does have a large impact overall. Amanda, this is probably a good time for a polling question. The one polling question we have. How often are you reviewing your quality indicators and quality measures? Are you doing it weekly, monthly, quarterly, or you're not sure how?
Okay, we're getting quite a few responses. I'll leave it up for about 10 more seconds. Okay, we have about 80% of people responding. And here are the results.
Good. That's very good. 59% on a monthly basis. That's perfect. Okay. And okay. So quality indicators and quality measures, where is this data coming from and what is it being pulled from? It's being pulled from your MDS and from your MDS data, and then it comprises itself of 15 measures. So really accuracy is the key on your MDS. If you want to have an accurate picture of your quality indicators and quality measures, we really want an accurate MDS. Medicare and Medicaid claims are also starting to play a part in this, and we'll kind of discuss that a little further into the presentation, but this is, I would say, 90% driven by the MDS. Okay, so the facility quality measure report. Amanda, if you could share this slide, that would be great. And I'm not sure if I'm going to see it, so let me know when it's up.
Okay, give it 1 second, it's coming. Oh, you'll just have to stop sharing your screen first, Kim.
Oh boy, I don't know that I want to do that.
Oh, wait, hold on 1 second. You will have to go back to sharing again, but I can do this. All right, I'm going to zoom in a little bit for those of you like me who need it.
Okay, so if you're not familiar with your quality indicators and quality measures, there are two reports that are pulled. Either you're pulling these from the iQuEST system. I know our organization, we're pulling this from Simple LTC. But if you're going to be looking at your quality indicators, quality measures, this is going to be the first form that you're going to actually populate. And this is your facility report. So you're going to see, like, to the right of that screen, you've got your MDS measures. There are 15 measures that are actually looked at. So we look at that, and then you have various percentiles. And so with this, they're actually, they have like this mathematical equation where they actually adjust the percent, but then it also um, kind of compares you to the state. It also compares you to the nation. But what I like to tell people when I'm going over this one-on-one with staff within our organization is I really like to look at the last column where your group, where you have the group national percentile. So that is something that I always have people look at. We look at this when it's 75 and above. So those are what I consider to be your problem areas. I often refer to quality indicators and quality measures as the report card to your facility. So this I refer to as your problem subjects. And then once we look at this, you go to the resident level facility. Do you have that one, Amanda? The resident level? And then I look at that, seeing which one of my residents has actually triggered in these measures.
Yeah, give me one
Of
second.
course, yeah. So you really need to have both of these reports side by side. So you have your facility where you look at your problem areas that have triggered. And then once Amanda shows us the resident level, and this is purely just for the people that don't know what your quality measures or your quality indicators are looking like, I just want you to be familiar with what the two reports look like so that you can eventually crosswalk them. But essentially, what you're going to see is you're going to see on the left side, you're going to see your residents. And then on the very top, you see all of the measures that you saw on the facility side. They're all listed on the very top. So if you have a resident that has triggered in this measure, you're actually going to see an X. So right now we're seeing some Bs. I'm not sure what the letter B stands for, but what we're looking for is the letter X. And that is indicating to us that that resident triggered under that measure. So you really need to have both reports to understand what is going on in your facility. Um, so far, is there any questions in and around these two reports? Because now I'm gonna show you how we're gonna crosswalk them and why have these residents triggered. So if there are no questions, we'll move forward.
Stop sharing. Okay.
Yep. Okay. And because I did a lot of talking without moving slides over, I'm just going to kind of go through some of these slides. Okay, so in your resident, the other thing that I want to kind of stress is that when you are generating this report, you really want to be mindful of the time frame that you're selecting. Um, so if you want to look at a month, I would be cautious that you kind of speak with your MDS coordinator, find out when that MDS coordinator has submitted. Hold, Sure. Sorry, technical difficulties here. Can people see my slides? No?
Not yet.
Hold on. I'm so lucky to have people in the office that take care of me. Thank you, Eric.
We got you. We can see it.
Okay, so it's important that you have both the facility level and the resident level in order to crosswalk. Now, I was talking about making sure that you are pulling these reports at the appropriate time of the month. So if you don't, this is not something that you want to pull at the very end of the month because you want to make sure that your MDS coordinator has submitted all of the MDSs for, let's say we're talking about the month of May, and you want to make sure your MDS coordinator has submitted all of her MDSs, his or her MDSs for the month of May. You want to give that a good 7 days for that information to get populated, to get scrubbed into whatever reports that you're pulling so that you actually have an accurate picture of what has happened that month. So if you're pulling May and you're doing this on May 31st, you're not going to be receiving an accurate picture. So just kind of be mindful of all of that information. Something that might be also a little bit perplexing is that if you're looking at your residents and they've triggered for something, but you're saying this resident did not have an MDS in the month of May, that's absolutely accurate. They don't have to have an MDS completed in the month that you're pulling this report. They just need to have an MDS completed in the last 120 days. So that is how that is actually reported. And so now that you have these two reports, so you have your facility report, you have your resident report. I recommend that you highlight the areas that have triggered under your MDS measures. And then on your resident report, I want you to do the same thing on the very top and then just highlight it down. And it's going to you'll actually be able to see which residents have triggered for which measures. So once you've done that, you're actually prepared to start reviewing issues on your potential report card. Okay. Any questions around that so far? Okay. Okay, so let's review the quality indicators and measures and what are the inclusions and the exclusions. So we're going to start with your report card. Because Florence Nightingale has never taken care of patients that we're currently taking care of. Amanda, you
Just
have
to
a question?
clarify, because I know you've been calling your quality measure report card from your CMS 5 stars. You've been using that phrase for years. I want to differentiate that's different from the scorecard that you get
Yes,
for your value-based purchasing from the state of Maine. Just to
yes.
make that distinction.
Yes, and during the last presentation, the Groot presenter, I like the comment that she had made. She basically called something her credit report card. So it's kind of like, it's very similar. So I call it my facility report card. I want to know what it's doing, but it's essentially, yes, it's very different, but But yeah, that's my term. I'm sorry.
No,
Report
that's
card.
okay. And I mean, it's very similar and there's some overlap there. So just, and I know our MDS coordinators on the call and a lot of our leaders know that, but I wanted to differentiate for folks that are newer to quality measures.
Yeah, that's always been my coined term. Sorry about that. Okay, so the first measure we're going to look at is pressure ulcers. So the inclusions for your pressure ulcers is if you have documented in section M that your resident has one or more pressure ulcers or an unstageable pressure ulcer, you're going to be included, obviously, into this measure. Exclusions, and I will tell you that the exclusions here are often dashes. So I just want people to be mindful with the dashes, and really dashes should be being used as a last resort, typically for an unplanned discharge or a discharge that has had to happen very quickly. CMS is really looking at dashes. If you have too many dashes, that's a trigger for CMS, and it can most likely result in audits and probably a payment reduction. So there will be payment penalties for the overuse of dashes. So just be very cautious about that. Another exclusion is if the resident was transferred to the acute care setting and or passed away during that 120-day period. So they will be kind of tossed out of this measure if that were the case. Okay. Our next, can anybody tell that this is restraints? And so the RAI definition of a restraint. So RAI is the Resident Assessment Manual. It's essentially the manual for the MDS. If you don't know what RAI, so I often say the RAI manual, which is essentially the MDS manual. So the RAI definition of restraint is restricting a resident's movement, restricting the access of their body. So if we have a resident that has a PEG tube or a G tube that's pulling at it and we're covering it and trying to stop a resident from actually pulling that out, that really could be considered a restraint. So the coin or the key to that would be is can the resident release like a seat belt? If a resident has a seat belt in their wheelchair, can they release that seat belt on command? Or can they remove a device that's actually stopping their movement? So if they can do either one of those, it's not considered a restraint, but the minute that they cannot, you really need to reassess or reevaluate that situation because you are looking at a potential restraint. And that is coded in section P, and pretty much every exclusion is going to be a dash. So I have it in the slides, but I'm not going to repeat it moving forward. Any questions so far? The next one is going to be falls and falls with major injuries. So I kind of combined these two. So there is the definition of falls, and you're going to see that some of the language, the terms in there are highlighted in red, and they're highlighted in red because those have been added to the definition of falls with major injury, and that addition took place in October of 2025. So there has been some revisions to the definition, and so I've just kind of highlighted those for you. Falls, so the regular definition of a fall per the RAI manual is an unintentional change in position where the resident comes to rest either on the floor or on the ground, or there's actually been a change in surface. So what I mean by that is if they were standing and they landed on their bed, that essentially could really be defined as a fall because now they've changed plane. They didn't land on the ground, but they did change the plane. So just be mindful of that. Um, Inclusions for falls, and this is just for major injuries here. Well, it can be for regular and for falls and for falls with injury. The one thing that is just with falls with major injury is that this will trigger on your quality indicators and quality measures for a full year. The exclusions to a fall is if the area hasn't been assessed, and this is new as of October of 2025. Pathological fractures resulting in a fall are excluded. The one caveat to that is that it does need to be documented by a physician. So a physician is the one that needs to be able to make that determination in order for you to actually claim that, and then that way it would be considered an exclusion. Okay. Any questions so far? Okay, I'm just going to keep chugging along. The next one is antipsychotic medications for both long stay and for short stay. Antipsychotic medications. So we have how are they triggered? This is essentially for your short stay residents right now. So if you do your initial MDS and you do not code that the resident has an antipsychotic medication on your next MDS, and you do code that they have one, that is when this measure is actually going to trigger. There's also pharmacy and encounter claims. We'll get to that a little later down the presentation. Remember when I said earlier, um, this is essentially all MDS information, about 90%. This is where we have a couple of issues outside of the MDS, which is the pharmacy claims and the encounter claims that are actually being tabulated into your 5-star rating, but we'll discuss that in a little bit more detail in a few minutes. Your exclusions for your antipsychotics are these 3 diagnoses: schizophrenia, Tourette's, and Huntington's disease. If those are checked off in section I, this measure is not going to be triggered on your quality indicators, quality measures. And of course, if anybody on hospice. The one thing I do want to kind of stress here is a couple of years ago, CMS identified that there was an uptick in the diagnosis of schizophrenia. So CMS has got kind of wise to that practice. And so what they have done is that they have actually audited charts where residents have been coded for schizophrenia, and they're actually checking that against other information to ensure that that is an accurate diagnosis for the resident. They are looking at PASSARs to see if schizophrenia is part of their PASSAR. And then they're also looking to see if the resident has had any encounter claims with a psychiatrist. And of course, they're looking at the DMS criteria to see. If they're not able to identify schizophrenia with any other checkpoints, CMS is going to penalize your facility, and they have enforced this. And what they are going to do is they are going to knock your overall 5-star rating down to a 1-star. So you want to make sure that you are very accurate with the diagnosis and not just nilly-willy coding schizophrenia. They really are wanting to see some meat and potatoes behind that diagnosis. So just be very cautious. Pharmacy claims. This is where I was talking about information being collected outside of your MDS. Pharmacy claims is one of them. And this focus is mainly for your long-term cares, your long-term stay residents versus your short stay. Short stay is anything under 90 days in your facility. Long stay is anything over 100 days in your facility. So your pharmacy claims, CMS is looking at. So I just want you to be aware, please be cautious if you have a physician that is ordering PRN Haldol for nausea. That is very common to see that with hospice, but we want to make sure that because hospice is an exclusion. So you just want to make sure if your resident isn't on hospice and your physician has this practice, be very aware of that because even though your resident has an order for it and it's been ordered by the pharmacy, you're going to get flagged. Your resident's going to get flagged for it, even though they have not been given a medication. Just by virtue of it being ordered, they are going to flag for this measure. So this is also something fairly new that has evolved. So if you're not aware of that, just be cautious. Your encounter data. So we had pharmacy claims. Now we have emergency room visits. You want to be cautious with emergency room visits because, I mean, I think we've all experienced sending a resident to the hospital because they're having chest pain to rule out fractures for various reasons, but then they always come back to you with also a diagnosis with I'm sorry, I'm jumping ahead of myself here. They sometimes they will come back and you know that they have received an antipsychotic because they're a little unruly in the emergency room. So if that has happened, that's a claim that a pharmacy claim because now they've been given an antipsychotic in the emergency room that could potentially trigger on your quality indicators and your quality measures. So just be aware of that. If it's given to them in the emergency room, it will be counted against you. The only exclusion is if they put that PRN antipsychotic in with the appropriate diagnosis of either schizophrenia, Tourette's, or Huntington's. Anti-anxiety and hypnotic prevalence. You have this measure and then you have it without the prevalence. So I've kind of combined both of these together. The exclusion is having the following diagnoses. I'm not going to read them to you. You'll be able to see them. And then for the measure that has anti-anxiety and hypnotic without the prevalence is having these diagnoses along with a prognosis of less than 6 months to live, being on hospice, and of course, the dashes. Okay. Behaviors affecting others. So we have the inclusions, and I believe that this is out of Section E. So if you have coded anybody with physical, verbal, being socially inappropriate, rejection of care, or wandering, this measure is going to be triggered. So I just want you to also be cautious about wandering. You want to make sure that the resident is actually wandering and not just walking around the facility because there could be that really could be two different issues. You want to be able to make sure that you're making that distinction. And wandering definition in the RAI manual is moving from place to place, but not knowing where they're going. So just make sure that you are kind of differentiating that. I have seen that being coded and not following the appropriate diagnosis. So a good audit for you to kind of look at. And then, your teeth look great, but then I think it looks like we might have to extract your tongue. I think that we have all felt like that at one time or another. Um, just trying to throw a little funny in there. Okay. Depression signs and symptoms. Your inclusions can actually be triggered in a couple of different ways, and it's all in and around your PHQ-9. So on your PHQ-9, the first two questions, which is, and the PHQ-9 is over a 14-day period. If they have answered more than half of the time on questions 1 and 2, which is having very little interest, feeling down or depressed, you're going to trigger for this measure. Also, you're also going to trigger if your PHQ-9 has a score of 10 or more. Your exclusions, if your resident is comatose and or there are dashes. Urinary tract infections. Okay, I really like this one, and this is probably the first measure that I always look at when I pull reports for facilities. So the inclusions of your UTIs is both of these issues have to apply. Okay, so we need to make sure that a medical provider has given us the diagnosis of a UTI. So just having a UTI and an antibiotic is not enough to actually code this on the MDS. You need this plus you are actually going to need an evidence-based document that meets the criteria. So you can either use the McGear's criteria or the Loeb criteria. Both are considered to be acceptable, but you need to be able to show per the criteria that they have met the criteria to actually have a UTI. So just by virtue of a physician ordering or indicating that this resident has a UTI and ordering an antibiotic is not enough to code this. The exclusions, if this is your initial MDS, so anybody coming to you from the hospital, a new admission that has a diagnosis of a UTI does not get counted in this measure. And then, of course, if the area has been dashed. So there's also another caveat to this that I want to make sure and add. So you know how I said if somebody has come to you from the hospital on admission, that UTI does not count. That is not the case if somebody has actually gone to the emergency room. So this is where I was going. We're going to the emergency room to rule out a fracture, or somebody's going to the hospital for chest pain. So they go and they get evaluated. Inevitably, they come back to you and they also have a secondary diagnosis of a urinary tract infection. If that's the case, you don't automatically code that. If they're going to the emergency room, they come back with that diagnosis, the facility is still responsible for completing a McGear's criteria or a Loeb's criteria and making sure that they have met the criteria. Just because they went to the emergency room and diagnosed with it is not an automatic check on the MDS. So just be mindful of that information. Any questions in and around that coding and how that gets triggered?
Just want to mention, Kim, we're down to just a couple of
I know,
minutes.
I know. I'm going to start talking fast now. That was my fear that I would talk too fast. Now we're just going to really kick it into
Let her rip.
overdrive. Okay, catheter in a bladder. So this is obviously coded if you have an indwelling catheter. This does not count external catheters, condom catheters, or intermittent and straight casts. This is purely going to be indwelling catheters or suprapubics, obviously. Okay, exclusions, obviously, if it's your admission MDS, if it's been blank, and your only exclusions are neurogenic bladder, which can be conditions of MS, Parkinson's, having a stroke, a spinal cord injury, or neurologic trauma. That could be conditions of why somebody has a neurogenic bladder. Or obstructive uropathy, which could be a result of advanced cancers, enlarged prostates, BPH, and or renal failure. I just want to be also clear that, so those are the only reasons why they would be excluded. I just want to be clear that it is still clinically appropriate for indwelling catheters to be used with stage 3 and 4 pressure ulcers that are in the healing process, somebody who's end of life, or somebody who needs to have prolonged immobilization because of multiple fractures. Those are all clinically appropriate. Just know that they still will trigger on your quality indicators and quality measures and not considered an exclusion. Okay, new or worsening bowel. So here, the inclusions, and this measure always needs a previous MDS and the current MDS. And that is true also with your ADLs and your mobility. So there are some that you just need to have two MDSs in order to do an appropriate evaluation for this. So obviously, anybody that now has a new issue with incontinence will be triggered. Or if you have somebody who has an established bowel and bladder pattern and now they need more assistance, they are going to be included in your measures. Your exclusions, obviously, because you need a second MDS to kind of look at this. An initial MDS or admission MDS is an exclusion. If your resident is comatose, and or if they have an indwelling catheter or nephrostomy tubes. Excessive weight loss, kind of self-explanatory because the inclusions is essentially the diet, essentially the question on your MDS. So 5% weight loss in a month or 10% weight loss in 6 months is how you're going to trigger. And your exclusions is an initial MDS, hospice, and if they have less than 6 months, a prognosis of 6 months or less. ADLs, inclusions, again, you need to have a comparison. And the reason people are going to trigger here is if they need increased assistance with their late loss ADLs compared to their previous. So again, documentation is key and a little challenging to manage. I will definitely agree with that. Definitions of increased assistance is essentially an increase in 2 or more points in one late loss ADL or 1 point coding in 2 late loss ADLs. And late loss ADLs include bed mobility, eating, transfer, and toileting. So those are the 4 areas that they're looking at when they're looking at this measure. Mobility, your exclusions are your ADLs and your mobility exclusions are both the same. Comatose, you're in it an initial MDS, a prognosis of 6 months or less, being on hospice, and being totally dependent on your ADLs are all exclusions to this. Okay. Any questions on that? I know that that was very quick. Just have 2 more slides and we're gonna just to kind of like do a full circle wrap. So quality indicators and your quality measures also kind of go hand in hand with VBP, which is your value-based purchasing. Okay. Okay. So there is quality-based, there is VPP, value-based purchasing on a CMS side. I also want to let you know that the state of Maine also has their own criteria. Maine is one of 9 states that have developed their own incentive measures to improve quality of care. CMS in 2006, they were looking at the following quality indicators in their VBP. So that was falls with major injury, infections such as your UTIs, and antipsychotic medications. In 2007, so next year, they're actually looking at 8 measures. For the purpose of this, I'm just kind of letting you know what the quality indicators and measures are. So those, again, are going to be infections, falls with major injury, and your discharge function score. The state of Maine actually is looking at staffing. And that is basically from your PBJ reports. The percent of turnover in this information can be found on Care Compare. We have resident experience, which is essentially going to be resident satisfaction surveys. And then we have the clinical measures, which are essentially the quality indicators and quality measures that we've kind of discussed. So in order to bring this full circle, it's very important that you're looking at your QI QMs for a couple of reasons. One, for the quality, because it can impact your admissions. It can impact potential employment opportunities for people coming to your organization. And then it really can affect insurance partnerships. And then as of recent with the value-based purchasing, it can have a financial impact. So it's very important that you know what your QI QMs are doing for your organization, what is triggering them, and then essentially developing a plan on how can you improve and decrease those numbers. So
Kim, I want to make sure that we've got 3 minutes left for the whole call, and I know some folks on have another call booked after this.
No, that's it. My next slide was, does anybody have questions?
The next slide was a cute baby. Folks, I know that you had some questions and comments in the chat, and some were answered in the chat. So thank you to some of our MDS gurus for piping in there. That's very helpful. What other stuff do we have questions about? Michelle is asking, she missed part of the chat because she was pulled out onto the floor, but she was asking about PRN Haldol. We have hospice referrals that often have these orders, or long-term care residents that go hospice, and then the nurses will recommend PRN Haldol.
So if you are hospice, you're excluded. So no need to worry about that. You just want to make sure that you just do not have a physician that is ordering that on a resident, not on hospice. So if anybody who has a PRN Haldol or a PRN psychotropic medication, not on hospice, even though they have not received it, just by virtue of it having been ordered, being processed through a pharmacy claim, will trigger your resident into this measure. So typically in the past, they had to have taken it in the last 7 days from your ARD assessment reference date. That's no longer the case. If they have the order for it and the pharmacy claim has been processed, they're going to get flagged.
Yeah, and that hospice exception, my understanding, is new to the changes to antipsychotics just this year. So
yeah,
some of those changes are good.
A lot of new changes, yes. We just need to be aware and stay on top of the changes.
Anybody have one last final thought or question? All right, mostly in the chat, Kim, we just have a lot of great job, Kim, and this was very helpful. So with that, thank you everybody for joining today. A special thanks to Kim, and thank you, Eric Pooler, for helping with some of our technical difficulties, and thank you all for your patience with our technical difficulties today. This has really been a great overview of the quality measures, and we're grateful for you sharing your knowledge to help all of Maine do better. So if you don't already, in just a moment, you will see a QR code on your screen. If you could please complete this brief survey just to help us gauge the quality of today's call, give us any feedback you'd like for what else you'd like to see in the upcoming months of QuEST. If you prefer a link, we'll drop that into the chat momentarily as well. Today's recording and the slides will be posted on the Rate Reform website, as they always are. They will also be posted to the SharePoint site by next week, and they will also be distributed to everybody on the QuEST email list by email. If you have any additional questions or you need a new invitation to the SharePoint, you can send that to oads help.nfquality@maine.gov, and we can get you help there. As always, we'll be sending those materials out by the middle of next week. And if you're already done your survey, thank you so much and have a nice day. I will leave the call open for just a moment for anybody wrapping up. Thanks again for joining, everybody.